Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. Welcome to the Southern Medical Association's Southern Medicine podcast. We are pleased to have Dr. Veronica Piesiak with us today. Dr. Piesiak is Emeritus Director of Endocrinology and is the Director of the Diabetes Center at Baylor Scott & White in Temple, Texas. Welcome, Dr. Piesiak.
Well, thank you. It's a pleasure to be here today.
Thank you for joining us. Today we are going to be discussing diabetes. Is there anything new about how to diagnose diabetes using the A1C?
That's an excellent question. The A1C has been used now for several years to diagnose diabetes. An A1C of equal to or greater than 6.5% suggests that the patient has diabetes. However, some of the new enhanced data tells us that we are not finding all of the patients with diabetes using the A1C. We're missing some of them. So remember, the other criteria are a fasting glucose of equal to or greater than 126, or a 2-hour post-meal glucose of greater than 200, or a patient with symptoms and a random glucose of greater than 200 at any time. But what they're emphasizing this year is we do need confirmation of these diagnoses. We've known for a long time that we need to have a glucose of equal to or greater than 126 on more than one occasion. And now they're suggesting we need to make sure that we also have the A1C on more than one occasion in order to diagnose diabetes. In addition to that, they are saying that in the same sample, we can get a fasting glucose and an A1C, and then we will be sure that we have two criteria for the diagnosis of diabetes at one time, which is much more efficient.
Why has the ADA recommended GLP-1 receptor agonists as second-line drugs after metformin for the treatment of type 2 diabetes?
Metformin has always been the first-line drug for diabetes now for many years because it is efficient and it has the best sustainability of action of any of the drugs we use for diabetes type 2. But metformin isn't always sufficient. So for many years, the ADA has said that all of the other drugs that we have available in our armamentarium are probably equally efficient. However, over the last couple of years, there have been some excellent studies showing that GLP-1 receptor agonists actually do decrease the risk of death from cardiovascular disease in patients with diabetes. And so this year, the American Diabetes Association suggests that they are second-line drugs. Remember that we all make our own GLP-1 hormone when we eat. And not only does it tell us we're full, it also helps improve insulin sensitivity and improve peripheral disposal of glucose and delay gastric emptying. So this is a very efficient hormone that we make, but it doesn't last very long in the serum. So now the GLP-1 receptor agonists bind to the receptor for GLP-1, and they are not destroyed by the enzymes that destroy native GLP-1. So they last a long time, and many of them can be taken once a week. So they are now an ideal drug that not only helps to decrease post-meal glucose and lowers the A1C by about 1.6% in most cases, but also helps our patients lose weight. So all in all, excellent set of pharmaceuticals, and that's why they have been chosen. In addition, the ADA and ACE, the American Association of Clinical Endocrinologists, also suggest that we can use SGLT2 inhibitors. Those are medications that decrease glucose reabsorption from the kidney filtrate. As a result, they increase urine glucose and move a lot of the glucose that we eat, about 380 calories worth, out of the serum and into the urine. These medications not only help control the blood glucose, they also are helpful in decreasing the rate of decline of kidney function. And some of them have been shown to decrease death from cardiovascular disease. So now we have two nice second options for the control of our patients with diabetes when metformin is not enough. And it also helps to prevent our patients from having to take daily or sometimes 3 and 4 daily injections of insulin.
What should doctors be telling patients about SGLT2 inhibitors when they say they have heard disturbing information about them on the television?
A very good question. We know that both the GLP-1 receptor agonist and the SGLT2 inhibitors have side effects. The GLP-1 receptor agonist, for example, can cause pancreatitis. Very rare, but we are told to tell our patients that if they have nausea, vomiting, and abdominal pain, they should stop their GLP-1 receptor agonist and call us right away because they may have pancreatitis. In addition, that GLP-1 receptor agonists in animals have been linked to a very rare kind of thyroid cancer, so we need to discuss that with our patients as well. In terms of the SGLT2 inhibitors, they can produce a number of side effects. They can result in diabetic ketoacidosis, and there's a black box warning from the FDA about that. That happens to people who do not drink plenty of fluids. When you're taking these medications, in order to keep from being dehydrated, you have to consume a lot of fluid. At least in my patient population in the summer, about 1.5 liters of non-caloric beverage a day, because these medications are diuretics and they cause fluid depletion because of the glucose that's being put out in the urine. If patients don't drink fluids and get dehydrated and they don't eat enough carbohydrate, they can develop diabetic ketoacidosis, which is a life-threatening disease. But again, this can be prevented by explaining to your patients plenty of fluids and enough carbohydrate to prevent ketosis. So they shouldn't really be on the keto diet when they're using these medications. In addition, the SGLT2 inhibitors have been linked to a problem with gangrene of the digits, that would be the toes, because they can cause dehydration. So again, drinking sufficient fluid is very important. And finally, the SGLT2 inhibitors have been linked to gangrene in the perineal area. We don't know the exact cause of that. It is fairly rare, but again, patients should have that discussed with them. All of the medications we use for our disease treatment have side effects, and it's very important as providers of care that we discuss these with the patients.
What lifestyle changes are recommended for patients with diabetes?
Well, this year and the last couple of years, the ADA has not given a specific dietary recommendation, although they said that exercise about 150 minutes a week is an excellent way to help control diabetes. In addition to that, last year they said that we really need to have some brisk exercise every hour. Just getting up and walking for a few minutes is going to be helpful. In terms of food plans, although the ADA doesn't have specific recommendations, many other sources do, and the Mediterranean diet has been heralded as an excellent food plan for patients with diabetes. It is a high fiber diet, it's high in plants, and it is low in red meat. And if we're looking in general at the diets that are recommended for patients with diabetes, those are the criteria. High fiber diets actually help delay gastric emptying, which improves glucose control in the post-meal period. In addition to that, plant-based diets have been shown to decrease cardiovascular mortality in a number of studies. And limiting the red meat we eat has also been shown to decrease cardiovascular mortality. So looks like we're eating less meat, more fish, more chicken, and more plants in the future, and walking more often if we can.
Thank you again for joining us. To subscribe to additional SMA podcasts, please visit sma.org/podcasts.